Okay, it says that it is live, but I can't actually see it on the Mind the Bleep page. Okay, there we go. There are people that have joined as well, so I'll just start. Hi everyone, welcome to the first Journal Club session with Mind the Bleep. This is something new we're starting just to introduce some research and guidelines and some insight into different specialties through some specific research articles on the Mind the Bleep platform. So today I'd like to welcome Dr. Deepak Nagra. He's a rheumatology registrar at UHCW, and he'll be talking about the British Society of Rheumatology management recommendation for ANCA-associated vasculitis. Thank you for joining.
Oh, thank you for the introduction. I'm going to discuss the guidelines. They came out about 4 weeks ago now, and it's an update from the British Society of Rheumatology guidelines from 2014. So the last time the guidelines came out, even I was a medical student. The authors on the guideline are a range of rheumatologists, ENT physicians, and respiratory physicians. The first author was actually a friend of mine, Catherine Biddle, and the question remains as to why now? Why should they release a new guideline now? And a lot has changed in the last 10 years. So there's been a few new trials, specifically the Advocate trial, which looked at avacopan as a steroid-sparing agent for ANCA-vasculitis, which met its endpoint in the phase 2 and 3 trials. And I think it's been a few years since the European guidelines have come out too. The guideline is also endorsed not only by the British Society of Rheumatology, but the British Thoracic Society, the UK Kidney Association, and the respective ENT Society and Vasculitis UK. So I'm going to go straight into the guideline. The objectives and the scope of the guideline was to address GPA, MPA, and EGPA. So 3 very separate entities when it comes to vasculitis, and it generally only talks about ANCA-associated vasculitis, not IgA vasculitis or any other form. And the first headline thing in the guideline is that it explains that all ANCA-associated vasculitis subgroups should be treated as organ-threatening or as an emergency, rather than in the previous guideline where there was mild, moderate, severe types of ANCA-associated vasculitis. For induction therapy, the guideline specifically states we should be using cyclophosphamide or rituximab, whereas previously azathioprine could have been used for induction. So azathioprine is a disease-modifying antibiotic drug. It's taken orally. And again, when you're unwell in ITU, sometimes intubated, it's not really an option. You need IV treatments. The guideline looks at the evidence behind rituximab and cyclophosphamide, comparing it to azathioprine. There were some notable trials which are referenced in the guideline, and rituximab and cyclophosphamide, as much as we know as clinicians, is superior, is now proven to be superior in the guideline as well. The guideline also discusses maintenance therapy. So it divides it into GPA and MPA maintenance therapy, which generally tends to be rituximab now. So if you've been induced with rituximab or cyclophosphamide, the best thing to do for maintenance is rituximab over and above methotrexate or mycophenolate. However, if you've got EGPA, you can consider mepolizumab as a maintenance therapy, albeit it's quite hard to get access to because you need a respiratory MDT and a specialist respiratory asthma centre usually to get hold of it. Moving on, they discuss ENT and subglottic stenosis in the guideline and the role for ENT physicians to be involved early. Again, they discuss mepolizumab in the ENT bit. There's some recommendations about service delivery and patient care with specialist vasculitis services, the role of CNSs in vasculitis management, and shared care decision making. When moving to the strengths of the guideline, it incorporates the latest trial data, multidisciplinary team input, and it's a practical guideline with implementation considerations. So it's also endorsed by NICE, and what is in the guideline is what happens in clinical practice. There are some limitations when it comes to the guidelines. So the availability of newer treatments such as avacopan, again, it is expensive. It needs an MDT for approval, but they do discuss the cost of newer treatments. They don't discuss cost of new treatments. They also touch upon there is evidence gaps in EGPA and ENT disease. They touch upon rituximab not being ideal for induction therapy, and cyclophosphamide is generally preferred due to the absence of evidence. The limited long-term data on rituximab in this area. The guideline discusses future directions, the long-term data on avacopan and B-cell monitoring, given the risk of hypergammaglobulinemia, if you're going to use rituximab for many years for maintenance, and when to stop. So usually at the moment, we would give it for 5 years, which is sort of the new thing. It used to be about 2 years in the previous guidelines. There are some service audit and quality improvement project ideas in the guideline. But generally, the headline figure is rituximab and cyclophosphamide for ankylosing is the go-to, followed by rituximab maintenance. And if you cannot use rituximab maintenance, should you consider methotrexate, or if there's a risk of toxicity, and then thereafter mycophenolate. That is, in a nutshell, the guideline. I've gone through it quite quickly within the first 5 minutes. It's not like a usual paper, so it's, when doing a journal club, you discuss limitations of a paper, strengths of a paper. Is it a randomized controlled trial? Is it a systematic review? Because it's a guideline and it's endorsed by many national organisations, there's not much in the terms of limitations that I pick up on. But yeah, that is the guideline in a nutshell.
That's really useful. Thank you. Can I just ask I guess we can all open it up for questions now if you're happy with that, and just discussion points. Yeah? Okay. So I'd like to introduce Kit and Lloyd, who are also on the call, and they're Mind the Bleep members, and can all ask questions. If any of the viewers have questions, feel free to put them on the YouTube page as comments or on the post, and we'll keep an eye on that and address them as well. I'll just start with questions then. I just wondered, what's the role of glucocorticoids and steroids in management of these conditions? And I know there's an increasing role of biologics and things, but just how does that weigh in here?
So I think when you've initially got a patient in A&E or acute medicine who's unwell and has suspected ankylosing, steroids are quick, they're cheap, and they're easy to get hold of. It's usually the first line management in any case, regardless of whichever guideline you're using. The role of steroid-sparing agents, so rituximab and cyclophosphamide, probably comes in slightly after. So you'd want to make sure there is no infection, set of blood cultures, making sure the HIV and hepatitis serology is negative, maybe getting a quantiferon, and that takes time. That probably takes 2 or 3 days. Okay. If the patient is someone who's having relapsing disease and has already had those tests done before, and you're quite confident, yes, the mononeuritis is due to this ankylosing, then you probably don't need to wait to give pulses of steroids. You could probably start with rituximab or cyclophosphamide alongside some steroid. I think there is always a role for steroid, as much as we talk about steroid-sparing agents with avacopan coming out, but it will always be part of the management plan.
Okay, fine. And in the community, when these conditions are managed sort of in the long run, I presume there's involvement from lots of different specialties. So is there any multi-specialty clinic that happens, or is it usually just each specialty focuses on the area?
Yeah, so I think in an outpatient service, each specialty will generally focus on their disease area. So if they're seeing the renal team as well, they will focus on the urinary protein creatinine ratio. They will look at the EGFR trends. If you then go to ENT, they will do a nasal endoscopy, have a look at the nose only generally. But in rheumatology, we try and bring it all together. So every single patient will have a urine dip and a PCR sent. We will ask them about nasal symptoms, and when doing the Birmingham Vasculitis Assessment Score, all of these domains come through. And I think rheumatology are probably good at doing disease assessment scores. The other specialties are not so good at doing them because they're not as good at looking for arthritis. So arthralgia and arthritis are commonly mixed up. Looking for a true myositis, not everyone is trained in looking for muscle disease, especially if you're not in rheumatology. So the ENT physicians will never do it. Generally, the respiratory physicians won't do it. But when we do come together, we usually have in the trust I work in now, a monthly MDT clinic where the lung doctors, the rheumatologists, the renal physicians, they'll all sit in one room together, and the patients will come in one by one, which is actually quite useful, given most patients won't just have one area of a problem. They will have lung disease, they'll have a bit of scarring in their kidneys, they may well have a mononeuritis, so you need everyone in the room.
Makes sense. That does make sense. And I'm sorry if I missed this bit, but what's the reason for the change in consideration of people having potentially life or organ-threatening disease when they initially present or with relapse?
Yeah, so it's a good question. So it's you could probably compare it to an MI. So when you've got a STEMI or an NSTEMI, everyone jumps when it's a STEMI, but it doesn't make the NSTEMI any less relevant. People still get admitted. People still have stents for the NSTEMI, although it gets somewhat downgraded in hospitals. I think ankylosing had always been sort of classified as sort of severe versus not severe. So severe being organ-threatening, life-threatening disease where you're being intubated and everyone's throwing loads of steroids at you, rituximab's coming in early, versus people who would have grumbling disease, but may not be sort of dying at the front door, but then they end up with loads of chronic long-term damage, which probably isn't fair. And they could have been treated more aggressively at the start and prevent these chronic elements of their disease. And I think that's why there's been a turn in making sure that everyone actually is classed as life-threatening, because generally it probably can kill. It can kill. We've seen people die from vasculitis and the complications. If you get chronic damage, you're more prone to having infections. You're more prone to having cardiorespiratory problems, deconditioning, and then in that sense, it becomes another health problem. So you're reducing the cost of further appointments and scans and bits and bobs.
Okay. Okay, fine. That makes sense. So from what I gather, it's more assessing them as being potentially organ-threatening to begin with, and then stepping down if it's deemed that it's not in that case. Okay, fine. I think those were some of the questions I had. I'd like to ask Kit, Lloyd, if you have any questions to ask them.
Yeah. So you mentioned that it's been 10 years since the last guidelines came out, and whenever there are new guidelines, there's usually key studies that led to these guidelines. Are there any key studies which you think are landmark studies that you'd want to highlight or signpost to us to say these studies were critical to this new guideline?
Yeah, so there was a few studies, and I think David Jane, who works in Cambridge, was probably a co-author on most of them. So the big landmark study for the new drug, avacopan, was the Advocate study. So in phase 2 and 3, and especially in phase 3, it was basically, I'll give you a bit of a background on avacopan. Avacopan is a complement inhibitor, C5a inhibitor. So it's a bit different to eculizumab and ravulizumab in terms of it doesn't cause pneumococcal infections, meningococcal infections. But what it does do is reduce steroid burden in vasculitis. And we use a lot of steroids, which then in turn gives you hypertension, gives you diabetes, which in turn then also gives you renal disease. And in the clinical trials, I think avacopan in the avacopan group, there was I think 71% of the patients were able to sort of be steroid free by week 16, which is actually an excellent outcome. That's not very long, 16 weeks.
Yeah, those are good numbers. Yeah.
Yeah, so the numbers were good in the avacopan study. So now the consensus is everyone, the NICE guidelines are everyone that has rituximab or cyclophosphamide should be eligible for avacopan unless they've got a contraindication. Okay, and I don't think most people do have a contraindication. So that's one landmark study. The other landmark studies were the IL-5 inhibitor studies, so the mepolizumab studies. And although benralizumab did do well in the studies, the guideline hasn't recommended it at the moment. So the mepolizumab studies, those who had EGPA were able to come off steroids, have disease, sort of steroid-free remission for a longer term, and were able to maintain disease, low disease activity for a longer time. So that was one other study. And then they were called the MIRA studies, MIRA. The other studies that were slightly older but relevant were PEXI-VASP. Now, PEXI-VASP was a big landmark study when it first came out. Again, David Jane is co-author on that, and I think he led it as well. So that was another study, and that was looking at if you should plasma exchange patients or not. And I think the European guidelines have also touched upon this as well when they were released in 2021 or 2022. And the big take-home headline sort of message from that was that if you've got a creatinine of over 300, you can consider plasma exchange. But plasma exchange was one of those funny sort of voodoo areas where we probably should stay away from plasma exchange. It doesn't really affect long-term outcomes at the moment. There's not good enough data to suggest it affects long-term outcomes. And then there were some other studies, ritazoram, which looked at rituximab as well versus azathioprine. There were some studies comparing mycophenolate to methotrexate. So some big studies, but I think Advocate was the big one, big new study that was referenced in this guideline.
Yeah, I think my next question will be, most immunosuppressive agents, they're quite toxic. They've got lots of side effects. Do you envision a future where we might not need them anymore? Because they require a lot of monitoring, which is costly, plus obviously the burden of side effects.
Yeah, I think it comes down to your definition of toxic. I think the patients who have this disease, the disease is probably more toxic than the rituximab we give to them or the mycophenolate we give to them. Most medicines will have a side effect, even if it's paracetamol. I've worked in a liver transplant center. There were people who came in, had paracetamol and had liver transplants because of paracetamol toxicity. So nothing is safe. Everything has side effects, even a pint of Carling. The medicines we use, methotrexate, we use them at low doses. They are tiny doses compared to in the cancer world. Rituximab, again, we use it at very small doses compared to those who are having it for lymphomas. Our most potent medicine is probably cyclophosphamide. That's probably the most potent medicine, the most amount of side effects. And even then, most people don't get a side effect because we give them ondansetron for their nausea. We give them chloramphetamine to make sure that they don't get itchy whilst having the infusion. We give them the mesanin to prevent the hemorrhagic cystitis, and that prevents the bladder cancer. So we sort of look for it well. So look for the side effect profile before we give them medicines. We give them PCP prophylaxis. The BSR have made a new guideline on disease-modifying anti-rheumatic drug monitoring, which is going to come out later this year, and which will talk about the need for blood monitoring and when it should be. At the moment, when you look at things like rheumatoid arthritis and even ankylosing, methotrexate usually a 3-monthly blood test. It's probably not needed. It can probably be stretched to 6 months. The guideline will address this. That's coming out. When you look at other monoclonals, TNF inhibitors, IL-6, they are generally quite safe. We don't get too many problems on them. Infection is the big risk, but most people don't get infections. So the BSR looked at this, and there's a chap called Andrew Rutherford who wrote a paper on the BSR's 2018 audit, I think it was, looking at infections and looked at who got infections in inflammatory arthritis. And it was generally those who had diabetes or were older. So those who are prone to getting infections probably will get infections. Not sure it's the drug itself. There are some drugs that we use, JAK inhibitors, that give you specific risks. So shingles is a risk seen in JAK inhibitors. Tuberculosis reactivation has been seen in TNF inhibitors. So each specific monoclonal antibody has its own specific risk profile. But collectively, they are generally a good bunch of drugs, probably safe drugs and life-saving drugs.
Yeah, that really changes the perspective and how you look at the drugs. Thanks for that.
Can I ask something about implementing the guidelines in NHS? Do you see any barriers like cost, or the doctors might not be so keen to switch from the practice for 10 years to the new recommendation, or just the cost?
Yeah, so I think that's already happening. So the guideline is in place, and avacopan is probably the newer drug that's NICE approved that people have been slightly reluctant to use, mainly because of cost. I think it's now we're looking at nearly, 18 months to 2 years since avacopan's been available, maybe longer now. I think a lot of people are using it. Every time you go to a national or international talk, someone is talking about it, so it's becoming more familiar. With regards to the use of rituximab and cyclophosphamide and using rituximab for maintenance, I think that's a big addition. That's a new thing. And a lot of people would have used azathioprine before because the original trials were azathioprine. A lot of people want to use methotrexate and mycophenolate as well because that's what they're used to. And even in our trust, we see patients having azathioprine or methotrexate or mycophenolate ahead of rituximab because they've only got single organ disease or what was previously thought to be mild disease. And I think it will take time, probably at least 12 months, for this for the attitudes to shift towards giving everybody rituximab. And I think that's where the role of the MDT comes in. You should have a specific person in your trust who leads the vasculitis service, who advocates for patients to have rituximab early. Even if it's only a 500 milligram dose of half a gram rather than a full gram, if they've got comorbidities, but they should all have B-cell depleting therapies, I think, over and above azathioprine, methotrexate, and mycophenolate.
Okay, perfect. I have a follow-up question. So this update is very new, like 2025. And for the next update, do you reckon it would be 5 to 10 years? And also, what would you expect for the next update?
I think it's early to think about what's going to be in the next update, only because we've only had this one for 4 weeks. I think the next update will highlight longer-term safety data on rituximab. So people who've had rituximab for 10, maybe 15, 20 years, what happens to them? The next big trial, I think, in the vasculitis landscape will be what happens to the IL-5 inhibitors. So what happens to benralizumab? Does mepolizumab stay? Will there be biosimilars? So now we have so many biosimilars for tocilizumab, adalimumab. Will that then mean that the drugs get pushed up the queue because they're now cheaper? That would be one to look for.
Perfect, thank you.
I wanted to ask something. Oh, sorry, was that someone else? Okay. I wanted to ask something more sort of clinically focused. What should a junior doctor that's coming to work, F1, F2, be aware of when they see a patient with ANCA vasculitis, having been on these new medications, just as background knowledge to be aware of?
So it probably depends on what the patient's turned up with. So if a patient has turned up with a chest infection, they've got a pneumonia on their X-ray, their curb score is 2 or 3, they're being admitted because they're needing 1 liter of oxygen, and they've got a diagnosis of ANCA vasculitis on rituximab every 6 months or 12 months and avacopan. The question is, do you stop the avacopan because you can't do anything about the rituximab because it's already in the system? And I think the current consensus is you could probably continue the avacopan. Probably doesn't make much of a difference for their pneumonia unless it interacts with the drug. If you're coming in with shortness of breath and maybe you've got a really high CRP and the X-ray doesn't show much, the neutrophils are somewhat normal, and you're considering a diagnosis of ANCA vasculitis, I think you should ring your rheumatology reg early, or rheumatology consultant, whoever's around, and I would have a very low threshold to send them to the CT scanner very quickly. Chest X-rays are good; they are really good, but they won't show nodules. Sometimes they miss cavities or cavitating lesions. They won't show you ground glass opacities, and I understand ground glass opacity can mean inflammation and infection, but they won't show you a lot unless it's long-term scarring. So have a really low threshold to put them through the CT scanner. Nowadays, CT scanners, the radiation risk is low. It's not very high. And the one thing I would say is people are very quick to jump for PET CT scans. A PET CT scan cannot diagnose a small vessel vasculitis. So when people are spiking temperatures and someone is convinced that they've got a vasculitis, you've got to remember it's only going to look for a large or medium vessel vasculitis, not going to look for a small vessel vasculitis. So some patients can be ANCA negative. So sending the blood tests alone is not the answer. Make sure you bring someone who's got some experience with diagnosing ANCA vasculitis.
Yeah.
Thank you.
You don't mind me taking you a little bit back to the basics.
Mm-hmm.
What is the commonest presentation that you see for ANCA vasculitis, and when should us as junior doctors suspect this condition? I'm sure you see things that they've probably been treated for all sorts of different things. When should our bells start ringing that this could be vasculitis?
Yeah, so ANCA vasculitis is it's not just one disease, it's 3 different phenotypes of disease. That's the first thing to understand. The word ANCA gets thrown around quite a lot, but it's EGPA, It's MPA and it's GPA. And MPA is usually MPA and eGPA are probably the two most severe diseases. GPA is a granulomatous disease. It probably grumbles for a bit longer, cooks for a bit longer before it, presents itself. But MPA and eGPA are probably the two more concerning features. And MPA normally presents with an AKI. If you're on the take and you're clerking someone, and someone's coming slightly unwell, vomiting, not feeling right, maybe slightly febrile, and their creatinine is 300, and their chest X-ray shows a small pleural effusion and some patchy consolidation on one side. That's probably the commonest thing. With GPA, it's similar. You'll get some nose problems. Sometimes you don't get nose problems, so it's really hard to say. And with eGPA, your eosinophils will be up. So that's probably the clue. So when looking at the full blood count, someone's come in short of breath or chest pain, someone's done a troponin, the troponin is 60 or 70. eGPA patients get cardiac involvement quite commonly. And then you look at the eosinophil count and it's maybe 1, 2, maybe it's 10, maybe it's 15, but it's usually quite high and out of context. And they've not had an NSAID or a new medicine or anything like that. And I think that should ring an alarm bell. The eosinophils. When coming to GPA and eGPA, I think if you see anyone with an AKI, anybody, before you ring the renal reg to say I've got an AKI and the patient's been on furosemide or something else, do a urine dip. Look at the blood and look at the protein and send it for either a PCR or an ACR, either one, whatever you can get hold of, send it to the lab, because that will probably give you your answer quicker than anything else. Because if the protein leak is 60, 70 or a gram, they've got blood, and they've got an AKI, that renal reg will come a lot faster, and the patient will probably end up with a biopsy very quickly, which will then show crescents. So the red flag features to look for are the urine dip, rather than just focusing on the creatinine and giving them a bag of fluids. By all means, give them a bag of fluids. Make sure that urine dip is sent. There's a reluctance to send urine dips because you give the pot to the nurse puts it on the side of the bed, and then it just never happens. And there is a really big reluctance to test people's nerves. So that's the other big thing I would say. Everybody that is breathing gets a chest X-ray, even if they've got a sniffle. Everybody examines the chest. Everybody listens to the heart sounds. Everyone's notes you look at, even if they've got an ejection systolic murmur, people will say heart sounds 1 + 2 because they've just put the stethoscope on the chest and then walked off. No one tests the nerves. Always look for a mononeuritis. It is a emergency, life-threatening manifestation. It is end organ damage for your central nervous system. And in those cases, we usually try to go for cyclophosphamide. It works quicker and it penetrates the nerve-brain barrier better than rituximab. So I think if I was going to say 3 or 4 things, look at the eosinophils, do a urine dip, and make sure you test their reflexes.
Good. That's good. Thank you.
I've got a question. So I'm actually Pete's trainee. So it's very interesting, this whole guidelines on rheumatology. Was there any reference to the role of the pediatric rheumatology in adapting these guidelines for children?
I don't think so. From when I read it, I don't think we touched upon pediatric rheumatology much in the guideline, if at all any pediatric rheumatology. I'm sure there is a paragraph or a sentence in there, but I can't recall it.
Sure, thanks. And yeah, I think I just saw the last sentence there about like all children and everything, but I was just wondering, so probably this guideline wouldn't be adapted at any point for kind of pediatric rheumatology then, that they might have a separate whole other guidelines.
I don't think it's addressed kids that much. I mean, I wasn't an author on the guideline. I had a friend that was on the guideline, but I'm pretty sure they didn't go into detail with pediatric vasculitis.
Sure, thank you.
And another thing on the pediatric bit, the clinical trials all referenced in the guideline were all in the adult population as well, which makes it hard to then discuss pediatric patients.
Yeah, fair enough. I can see that.
That was all really useful discussion. I just wanted to ask sort of, your views on just, this is branching out now from this specific journal club to just your any guidance on sort of rheumatology and it as a career for people that are watching, just in a few sentences what they should think about and consider.
Yeah. So the landscape of rheumatology is changing quite rapidly in the United Kingdom. It used to be a Group 2 specialty, and before I joined, now it's a Group 1 specialty. So you have to do both rheumatology and general internal medicine. And I think the general internal medicine bit discourages people from applying to rheumatology. Generally, it's a well-liked specialty. It's pretty outpatient based. So my week this week is 4 outpatient clinics and a general internal medicine ward round on a Wednesday, which is tomorrow. I see depending on the day in the clinic, between 5 to 10 or 11 patients in clinic, and it will be a range of early inflammatory arthritis clinics, so rheumatoid arthritis, and you'll get some ankylosing spondylitis and psoriatic arthritis in there as well. Some centres will see gout, some centres won't see gout because they will say, it should be managed by their GP. But I think tophaceous gout or gout with erosions, we generally see in the hospital setting. I will do a CTD clinic, which will have a mix of vasculitis, so ankylosing, it will have PAN, it will have Takayasu's, there might be some GCA in there. And I will see patients with lupus, Sjogren's, systemic sclerosis, so a lot of different pathologies. And then you'll, from time to time, normally new patient referrals see someone with some obscure symptoms. Maybe they've got a big spleen and, maybe their tryptase is a bit up, and you'll somehow find someone with systemic mastocytosis and then be calling hematology or immunology as to what to do with this patient. We are seeing a lot more monogenic vasculitic syndromes. So things that are sort of DADA2, I'm not sure if you guys have heard of it, or other syndromic illnesses. We're seeing a lot of those. Rheumatology as a whole, because cancer rates are up and people are using more PD-1 inhibitors, pembrolizumab. We're seeing patients who have had checkpoint inhibitor arthritis or myositis or the very well-dreaded triple M syndrome. So complications of other diseases we're seeing in the rheumatology clinic. The rates of osteoporosis are going up very, very high because people are living longer. And depending on where you work, either rheumatology will look after it or endocrinology. In my current trust, it's rheumatology. So we get a lot of inpatient referrals for people who've had fractures, which then creates outpatient work. So there's a lot of work to go around. As a trainee, you can, what I sort of describe as become an interventional rheumatologist. It's a self-made name, but you can learn to scan. Instead of sending your patients for outpatient ultrasounds, you can develop that skill yourself. There is a BSR course, there is a ULAR course, you can get accreditation. You can do a case accredited course, which is what the radiologists do. So medically, legally, it's quite sound. You can do injections, so you can do nerve blocks in clinic. So we usually do suprascapular nerve blocks. I haven't done a genicular nerve block for knee pain in a rheumatology clinic, although I've learned how to do them from a course. And again, so the steroid injections we'd give in clinic are for knees, shoulders, we'll do wrists. Sometimes we'll do MCP joints, PIP joints. I've done ankles, I've done toes. We generally tend not to do sacroiliac joint injections. Normally tend to send those to radiology to take longer, and I'd rather do them under ultrasound or image guided. Rheumatology has a lot of trials, so if you wanted to do research, there must be numerous amounts of clinical trials in rheumatology. For rheumatoid arthritis, there's trials for gout at the moment. There are trials for lupus, systemic sclerosis. There's loads of trials. So depending on where you work, there's opportunities to get into research. And if you haven't already got into research and you want to, I would go and do the Good Clinical Practice certificate online from NIHR. And if your local centre is running trials or running this program, you can do the NIHR PI or Associate PI scheme. It will look amazing on your CVs and your applications when you're applying to higher specialty training. What else can you do in rheumatology? You can do a PhD, you can do an MD. I did an MD, research MD, and mine was on the immunology of rheumatic disease, quite specifically looking at what happens to pneumococcal vaccine antibodies in immunosuppression. You can do a master's degree, you can branch out and do rheumatology and then soft tissue musculoskeletal pathology. So my next thing I'm going to start in September is a master's in sports and exercise medicine. So a lot of soft tissue stuff. It's not in the rheumatology curriculum, no one teaches you, but I can guarantee you every second or third patient will have a soft tissue pathology alongside their rheumatoid arthritis or lupus in clinic, so it helps you that way. Again, if you didn't want to work in the National Health Service, there's always private work. Again, you can do research and fund your life that way. So there's lots to do in rheumatology. It's not just a specialty that looks at rheumatoid arthritis anymore. It's gone a lot wider than rheumatoid arthritis alone. Yeah, it's fun. The people are nice. Usually the nicest doctors in the hospital. We don't really shout at people. So if you're interested in rheumatology, I would go to BSR. It's the conference in April every year. Try go to EULAR. That's the European conference. It's actually in London next year for the first time in 10 years. So it's in the country. You can go to the BSR's case-based conference, which is in Cardiff in November. It's not that expensive. It will get you points for CPD. And you can always come to the Midlands Rheumatology Society conference, which is generally, I think, free. Happens twice a year. This year it's in October in Derby, I think, and it's in March the year after. Usually at football stadiums, so it's quite cool. But yeah,
that's a really useful introduction into sort of the broad scope in rheumatology at the moment. I wondered if anyone else had any questions. Otherwise, we can start closing the session.
I have a question. So I think everyone's talking about AI in medicine. And do you see AI it's playing a role now or in the future in the area of rheumatology?
Yeah, most definitely. So there is a study going on in University of Birmingham, and I think Andrew Filer and his team looking at AI for ultrasound. So the computer will scan the hands for you and interpret the images, and they just give you a report and tell you whether there's sinusitis or not. You don't have to do anything. So definitely in imaging. With diagnostics, I'm not sure where we've come with AI at the moment. Only because you can have an antibody and have the disease, but you can also not have the antibody and have the disease. So I think for diagnostics, with regards to looking at serology and symptom burden, it's probably still behind. But I'm sure there is someone who's doing a PhD or research on this at some point, and it will be with us in the near future. I think ChatGPT has changed a lot of things. People are using it for research. People are using it to think of diagnoses and differentials. I myself have used ChatGPT. When I'm stuck, I just get it to talk to me, bounce ideas off it. So AI is definitely coming. Whether it will take our jobs or not, I have no idea. I don't think it will take our jobs, but it's definitely coming.
Well, interesting. So you've used ChatGPT, and as a rheumatologist, do you think ChatGPT is accurate or like clinical relevant?
It is definitely not accurate. It comes up with some garbage sometimes. If you put, I've got joint pains and my CRP is 18. What do you think I have? It will come up with loads of nonsense. But I like to play around with it. I think it's useful. So when I've used it in clinical practices, if someone's got a really complicated phenotype of disease, you're looking for a monogenic vasculitic disease or something really, really syndromic and rare, I would ask ChatGPT to give me a review of the literature for these presentations. Are there case reports? Who wrote them? That's the kind of thing I use it for. Not to ask it like, someone's got a CCP antibody of 210 and a swollen finger. What is the diagnosis? It will give you the diagnosis of rheumatoid arthritis. It will also tell you the patient's got 100 million other things which are not true.
Right. Thank you.
Okay, I'm taking that as no one has any more questions. Really appreciate your time today for talking us through this guideline and discussing rheumatology with us. I'd like to ask the attendees to fill in a feedback form now, if that's okay. And that's how you can access your certificate of attendance as well. Let me just share my screen. Okay, so this was our first journal club. If anyone's interested in contributing to further journal clubs or has any questions about it, feel free to email us as well on the email that's shared on the screen. I'll leave it on for about a minute or so, and then you can just end the session. So the feedback form will take you to the Mind the Bleep webinar page, and then there'll be a form on there to complete, and that should provide the certificate for you. Okay, fine. I think that's it for the first Journal Club session. Thank you again, Dr. Nagra, for joining.
Cool.
Right.
Thank you.
Bye.
Thank you. Thank you.
Thank you very much. Very interesting.